covered and not covered under this program, and how to identify programs in your community or region. And just to start, I have one question that I wanted to ask. The question that will be coming up in your screen is, do you currently have a diabetes education program in your practice or work with one closely?
So it looks like about 80% of you do have a program that you work with already in mind, and those of you, about 20%, are probably in the process of looking for one or building one.
Great. Well, thank you so much for participating. It's actually great information for us to know here at the Department of Health. With that, I wanted to move on to starting the presentation. And I wanted to first start with an overview of where are we at with diabetes in the world, first of all. And I wanted to start with a couple of key things. In 2014, the global prevalence of diabetes was estimated to be around 9% among adults aged 18 years old and up. That is equivalent to 347 million people worldwide having diabetes as of right now. In 2012, an estimated 1.5 million deaths were directly caused by diabetes. More than 80% of diabetes deaths occur in low and middle income countries. Total deaths from diabetes are projected to rise by more than 50% in the next 10 years, that's worldwide. And for me, that's actually an interesting point, just because it mentions that low and middle income countries are the ones that are suffering the most. But we can also see in our own country that populations that are within that category also struggle the most. And we'll talk about it later on today. In 2030, which is the World Health Organization, projects that diabetes death will double between 2005 and 2030. Diabetes being the leading cause of blindness, amputation, and kidney failure. Now let's look at what's happening in the United States. Diabetes diagnosis, looking at this diagram that I have there, increased by a factor of 4 in the last 32 years. From the 1980s to 2012, that's just basically a staggering amount of change that happened in those 32 years. This map shows the reported diabetes diagnosis, as I already mentioned, in the United States. The percentage currently being around 9.3%. The diabetes report card is published by the Center of Disease Control and Prevention, CDC, every 2 years to provide current information on the status of diabetes in the United States. Now let's looking at some infographics that have been developed, and that's again these infographics can be downloaded. They're on the left side upper corner of your screen. You're welcome to download all the information that I have there, and also you can go into the CDC website and download it from there as well. Diabetes currently costs about $245 billion in medical costs, lost work and wages for people with diagnosed diabetes. People with diabetes are at 50% higher risk of death than for adults without diabetes. Approximately 86 million people, which is more than 1 out of 3 adults, have pre-diabetes. And worst part of it is that 9 out of 10 do not know they have pre-diabetes. In the next one, 29.1 million people have diabetes in the United States. Out of those, there are about 21 million people that have the diagnosis and about 8.1 million people that are undiagnosed, meaning that around 30% of the people with diabetes are undiagnosed currently. In the next slide, 2 out of 5 Americans will develop diabetes in their lifetime. And I can relate one story just when I used to work in a primary care clinic, when we will see patients coming in just because they wanted to follow up with a primary care provider due to a job requirement. If they were drivers, for example, that's something that they have to do mandatory. And when they will come in, they will have lab work done, and then will soon be told that they were diagnosed with diabetes without them even having any symptoms or anything. They will be extremely shocked of things like that happening to them. Or other people that have family history, that were feeling a little bit ill, were in denial as well, just because, again, information not necessarily being shared with them or what could be done in order to either prevent it or minimize symptoms that could arise due to uncontrolled glucose levels. In the next slide, more than 1 in 10 adults have chronic kidney disease. Again, this could be due to other conditions such as hypertension or other chronic conditions that could arise or lead to kidney disease, which is basically damage of filtration mechanism of the blood in the body. But if we look at the next slide, you'll see that 1 out of 3 people that suffer from diabetes will have a chronic kidney disease, which is just amazing information to me to find that out. In the next slide, diabetes, again, retinopathy affecting people. 4.2 million people age 40 and older have diabetic retinopathy. And again, when I used to work in a primary care clinic, we will see this happening to our patients coming in with variation, not necessarily knowing why was that happening, not necessarily thinking much about it, just because they will feel that it comes and goes and that's something that they get used to. But again, information being the key of how it can actually help them improve that condition. And in the next slide, it is expected to increase by a factor of 4 in the next 35 years, the amount of people that will suffer from diabetic retinopathy. So from 4.2 million to 16 million people in the next 35 years. Now let's look at what's happening in our state. Based on the 2012 Behavioral Risk Factor Surveillance System survey, an estimated 8.3% of adults 18 and older in Washington, which is equivalent to 463,000 people, have the diabetes diagnosis or self-reported to have diabetes, predominantly being type 1 and type 2. Again, the data being self-reported. In the next slide, we can see basically the trend on how it looks, have been looking for the last 20 years or so. And as you can see, it's an upward trend in regards to the amount of people that get diagnosed with diabetes. Diabetes has increased steadily from 4% in 1993 to 7% in 2010. And again, this is similar trends that we see nationwide. After 2010, a break in the trend appears because the data for 2011 forward are not comparable to the data from earlier years due to changes in methods of collecting and analyzing the BRFSS data. Since 2011, has remained around 8%, slightly lower than the national average again, which is 9%. Future trends in diabetes prevalence and incidence, prevalence being the total percentage of people with the disease at a given time, and incidence, the rate of newly diagnosed cases at a given year, being currently uncertain. After doubling over the past 2 decades, nationally representative data show a potential slowing of prevalence and incidence between 2008 and 2012. However, continued increases in the prevalence and incidence in some high-risk subgroups like non-Hispanic blacks, Hispanic populations, though with a high school education or less. Increases, again, reflects changes in demographics. More people with risk factors or more people with diabetes living longer. And an enhanced detection of diabetes cases could be the reason why this is also an upward trend. Reasons for the slowing down are difficult to determine though, but they be attributed to concurrent slowing in the growth of obesity and changes in the testing that alter how many new cases of diabetes are detected. Even with the slowing down of diabetes incidence, we expect the number of people with diabetes to remain high. And again, this data being self-reported. So in the next slide, I was able to find out more information in regards to how it is affecting us at county level. And again, this information you can find in the CDC website as well as has been downloadable on the upper left corner of your screen and is information that has been obtained from the Diabetes Epidemic and National Report. And in this slide in particular, I wanted to point out Azotin, Columbia, Adams, and Gray Harbor counties have the highest rating in the state currently with the diagnosis, and San Juan, Ferry, and Jefferson counties have the lowest one. And again, this varies throughout years. So on the left side, you'll see is information that has been collected from 2010 to 2012, and on the right graph, you will see that it's just basically the year 2012. And I'm sorry it doesn't show very well the names of the counties, but again, that information can be downloaded from the CDC website. So the next slide, you can see now the prevalence due to background, as well as due to educational level, as well as to income level. So after adjusting for age, fewer non-Hispanic white adults have diagnosed diabetes than most other racial and ethnic groups, with the highest prevalence among American Indian and Alaskan Native adults. Washington's Hispanic Latino population has significantly higher risk of type 2 diabetes and is growing faster than the rest of the population. So it is likely that will include an increasing portion of all people with diabetes in the future. After adjusting for age, people of lower socioeconomic position, as measured by income and education, are more likely to have diagnosis of diabetes. Adults with income less than $25,000 are twice as likely to have diagnosed diabetes as those with incomes of $75,000 or more. Adults with high school education or less are nearly twice as likely to have diagnosed diabetes as those with college degree or more. Differences in health behaviors, access to preventive health care services, access to materials and social environments that make healthy behaviors easier to adopt, and effects of stress may account for the relationship between socioeconomic position and diabetes. So continuing with the information, based on 2012 Behavior Risk Factor Surveillance System survey, an estimated 8.3% of adults 18 and older in Washington, again, which is equivalent to 463,000 people, have the diagnosed diabetes, predominantly being type 1 and type 2. Washington yields an estimated 172,000 adults with undiagnosed diabetes, and that's basically information that has been extrapolated from a national survey that was done, and with that information, we were able to generate our data for the state. After doubling over the past 2 decades, nationally representative data have shown a potential slowing of the increase in the prevalence and incidence of diagnosed diabetes between 2008 and 2012. However, there are continued increases in prevalence or incidence of diabetes in some high-risk subgroups, including non-Hispanic blacks and Hispanic subpopulations, and those with a high school education or less. High-risk subgroups, non-Hispanic, black, and Hispanic population, and those with high school education or less. And now let's look at the cost of diabetes in Washington State. Using the American Diabetes Association Cost and Office Financial Management Population Estimate, we estimate that in 2012 in Washington, type 1 and type 2 diabetes combined led to $4 billion in direct medical expenditure, including institutional care, outpatient medication, and supplies. In addition, they cost $1.36 billion in lost work due to worker premature mortality, absenteeism, and reduced productivity. Following these trends, we expect to see an increase in cost of about $1.5 billion from now until 2024. We're unable to distinguish between the cost of type 1 and type 2 diabetes due to constraints described in the methodology used by the American Diabetes Association. Other research studies combined with Washington-specific data allows us to estimate the 2012 direct medical expenditure attributed to prediabetes, which is equivalent to $709 million, and the expenditure attributed to gestational diabetes, which is equivalent to $22.7 million. Now, I have another question that I wanted to ask. Do you currently work with the following: certified diabetes educators, health educators, community health worker, patient navigators, chronic care coordinators, promotores de salud, or none?
You're welcome to check all that apply, too. You don't have to choose one. So it looks like about 60% of our audience today is working with certified diabetic educators. We have health educator, patient navigators, and care coordinators also being part of the team providing care. Thank you.
Great. Well, that's great information to find out. And I'm assuming also as well, it's not just one specific one to each location. I'm sure that multiple ones working in many different organizations. So not just one, which is great. Thank you so much for that information. And that leads me to this. For me, diabetes education is really important in order for us to be able to create change. Diabetes, I believe, is unlike other diseases. There are a lot of other components to diabetes, such as diabetes disease process, nutritional management, physical activity, medication, glucose monitoring, and psychosocial adjustments that people have to actually start to think about. Diabetes education makes you more aware of diabetes, what it takes to treat it, and gives you the power to control it. Diabetes education allows you to better incorporate education into your life and make the necessary changes to improve your lifestyle. Comorbidities such as hypertension and dyslipidemia and kidney disease also are linked with diabetes. It's not just a condition that comes by itself. But diabetes education plays a key role with diabetes management, because diabetes requires a daily nutrition management, daily thoughts about activity and exercise, daily monitoring, as well as daily intake of medication. The epidemic of diabetes continues to increase at an alarming rate throughout the world. Knowing that diabetes is a complex chronic condition that requires both high-quality clinical care and effective self-management. As the world prevalence of diabetes increases, efforts to promote diabetes self-management education are critical to reducing the human and economic burden of diabetes. Also remember, diabetes does not travel alone. As I already mentioned, there are comorbidities that are linked to it. In the next slide, I wanted to show, I mainly talk about two different types of diabetes, type 1 and type 2. And as you can see in this slide that I'll explain in a little bit, so if we start with a healthy person, and let's start with type 1 diabetes, you start with a healthy person, and unfortunately, there's no cure for diabetes. There's no way to prevent it. If you have type 1 diabetes, you develop it due to family history, disease to the pancreas, or an infection or illness, and that's why people develop type 1 diabetes. But with type 2, it's a little bit different. We have risk factors, such as being increasing weight, having high blood pressure, high glucose levels, abnormal lipid panels, being inactive, and that could lead to prediabetes, which are abnormal glucose levels, not quite so high to be diagnosed with diabetes, but already going towards that direction. And if the numbers are not well controlled, then it could lead to, again, developing diabetes. Soon after that, either if you have type 1 or type 2 diabetes, if one doesn't have it under control, then it could lead to complications. And complications could lead to hospitalizations. And if nothing is done, or treatment is not there, or education is not there, it could lead to premature death. So again, for me, diabetes education plays a key role. And I wanted to talk about the roles that are can enhance this particular area. So a key member that provides education will be the certified diabetes educator. A certified diabetes educator is a qualified health professional that possesses comprehensive knowledge and experience in diabetes management, prediabetes, and diabetes prevention. A certified diabetes educator educates and supports people affected by diabetes to understand and manage the condition and promote self-management to achieve individualized behavioral and treatment goals that optimizes health outcomes. In January 2014, there were 504 certified diabetes educators in the state of Washington, which corresponds to about 1 for every 930 people with diabetes in the state. Again, and some geographic areas may be completely without access to a certified diabetes educator, but that doesn't mean that there are no other roles that can actually support that area. And as already mentioned, and that's why I asked that question originally, we have health educators, we have chronic care coordinators, we have patient navigators that can help alleviate and bridge that gap in regards to education. Again, with the supervision of a medical provider, a nurse practitioner, physician's assistants, etc. But it can help alleviate that gap, as well as it can help connect with people in their community, such as utilizing as well community health workers, which nowadays we are seeing that it can help meet the patients where they are at. In the next slide, we can see an algorithm that has been created by the American Diabetes Association as well as the American Association of Health Educators, or Diabetes Educators. The Diabetes Self-Management Education and Support in Type 2 Diabetes. And this was a joint position statement of the American Diabetes Association and the American Association of Diabetes Educators and the Academy of Nutrition and Dietetics that have developed this algorithm to support diabetes education and diagnosis, medical business assessment, complications, and transitions. The diabetes self-management education and support has been shown to be cost-effective by reducing hospital admission and readmissions. And again, as you can see with these algorithms, it shows a continuum. Every single point in the patient's care, education can be delivered. Either a diagnosis, which is, I believe, one of the most important key points for us to be able to give education to our patient population in order to be able to have better success in regards to diabetes management. Annual checkups, as well as then every 3 months or every 6 months, depending on when you have your patients coming back for lab work that needs to be done, as well as in when complications arises or when they are needed to transition of care. So I had a question, another question. What percentage of your population can bill for Medicaid? Less than 10%, 10 to 30%, or more than 30%?
So it looks like we have about 2/3 of you who have a pretty good sized Medicaid population in your clinic. And then we have one clinic that's got a medium-sized Medicaid population. Thank you very much.
Well, again, thank you so much for answering this. This is valuable information because it lets me know a little bit more about how these programs can actually support in our state. But as well, don't feel alarmed if you haven't responded. I know that sometimes this information, we may not have it, and this could actually bring up more questions later on, and understanding of what programs are available out there that my organization can be a part of. So again, the purpose of diabetes self-management education. Why is it so important? Well, educates participants in nutrition management, it supports with medication management and understanding, and all these points that I have there on that slide are utilizing the 7 self-care behavior essentials for successful and effective diabetes self-management that were created by the American Association of Diabetes Educators, which encompasses healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risk. And all of this help patients make informed decisions make changes in their behavior that supports their self-management efforts and improve outcomes, and cope in the physical and emotional aspects of the condition. How can we support this? Well, Medicaid reimbursement exists for diabetes self-management education programs. Medicaid is also known as Apple Health, and it utilizes a system that is known as fee-for-service, which is the general payment method the agency uses to reimburse providers for covered medical services, and has been implemented to support preventive health services for this particular program and provides medically necessary diabetes education to eligible clients. And in the next slide, I wanted to show, again, this is kind of like a rough data that was created, and it shows in this particular slide the amount of hospitals that are under this particular program. We have 48 hospitals in the state that have been accredited for Medicaid reimbursement for diabetes education. This information is on the DOH website, and another website, another website was utilized in order to create this map. Currently, we're waiting for our epidemiologists to develop a more accurate map. In the next slide, we have now the data that shows the amount of clinics that we have in our state that are under this program. We have 65 clinics in the state that have been accredited for Medicaid reimbursement for diabetes education. And one thing that I wanted to pinpoint from these two maps that I've shown, as you can see, most of the organizations are located within I-5 from north to south, and not necessarily so much in the east side. And again, we don't necessarily know what could be the reasons of why. Maybe some organizations don't have the patient population that could bill for Medicaid in the east side. But for me, at least, it brings up more questions that I would like to hopefully get answers to and support our community the best that we can. But that leads me to the next point. If one organization would like to apply it, or if you know of organizations that maybe could benefit from this program, there is an application that they can fill out and submit to the Department of Health, in this case myself, and I can support you in the understanding of how this application needs to be filled. So in this particular page, and I'm sorry you might not be able to see the page that I'm showing in the slide, but you have access again to the application on the download box that is located on the left side on the upper corner. The key things that I wanted to talk about in this particular slide were the NPI number, which is the National Provider Identifier number that is linked to the application. So in the first page, basically one fills out the name of the organization, address, so forth and so on, as well as the NPI number. And for me, the NPI number is valuable information for a couple of reasons. The first one being that the NPI number is utilized in order to, is attached to an indicator in order to allow organizations to bill Medicaid for diabetes management programs. And the other thing is that it gives us, it lets you know information in regards to the certification process. And if somebody has been certified already by, or has been recognized already by the American Diabetes Association, as well as the American Association of Diabetes Educators, or as well as the Indian Health Services, then they will need to only submit the first 2 pages, and they don't have to worry about the whole package. So that's on the first page, basically, of the application. And again, you have access to it on the, you can download it from the downloadable box that is on the left upper corner of your screen. And the next one, you can see actually shows the page. And in this one, it basically asks for information of the current diabetes team that you have in place. And for people that, or organizations that do not have recognition from the American Diabetes Association or the American Association of Diabetes Educators or Indian Health Services, then they will need to submit 6 hours of continuing education that have been attained from the last 2 years, as well as information in regards to the team that you currently have in place in your organization in order to deliver this curriculum, and as well as filling out the rest of the application. In the third page, we require information in regards of your current curriculum that you have in place, as well as the assessment that you do in your organization for patients that are coming in to receive this program. And for organizations that have already been accredited or have credentialing from the 3 organizations that are already mentioned, then they do not have to submit this part of the application. So what are the qualifications? Well, first of all, you have to have a provider, either being a physician, advanced registered nurse practitioner, physician's assistant, registered nurses, registered dietitians, in your team that are able to or are allowed to in order to bill for Medicaid. Also, you have to have a program, and in the program you have to have educational objectives clearly stated for the following: what is diabetes, nutrition, exercise or physical activity, prevention and of acute complications as well as chronic complications, monitoring, and medications. Once DOH gives its approval, your National Provider Identifier, your NPI, will be linked to an indicator allowing you to bill to Healthcare Authority for reimbursement. And again, this specific information, if you don't have a program already in place in your organization, you could utilize the information that is in the American Association of Diabetes Educators, which they have the self-care behaviors as a framework that you could utilize in order to implement it in your clinic. And those ones are, again, being healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risks. And there is also a file that is on the downloadable box with references to all the information that I'm mentioning already. So you're welcome to download that and find out more about it. And also you can find it on the American Association of Diabetes Educators. So what is covered? Well, it covers 6 hours of diabetes education and diabetes management per year, which is equivalent to 12 units. Every unit is a half an hour increment. One may bill in single units or multiple units at a time. Single unit being 30-minute appointments, one-on-one, or it could be utilized as a group setting as well, where you have a class being delivered that takes longer than half an hour. And you can actually submit or ask for additional units as well. And I believe that this part of the information is not necessarily out there as much, but that is actually available to patients that are in need, and then as well as a way to be able to sustain, to an extent, the programs that we have in place. So what is not currently covered? Well, services provided by an individual or facility that has not been approved by the Department of Health. Services by providers that are not approved to bill Medicaid, and services that are expected part of another program provided, such as school-based healthcare services or adult day health services. So when one is submitting billing for reimbursement, there are certain codes that are required in order to be able to get reimbursement. Currently, we have 3 different codes, but 2 that you see in your screen. So those are basically for clinics. So you have the G0108, which is basically for individual visits, one-on-one visits. The rate of reimbursement is $31.53. And code G0109, which is utilized for group settings. And the rate of reimbursement for that one is $8.35. And again, for if you would like to ask for, if you have a patient that will benefit for more time, there is a couple forms that are needed in order to ask for more time to be allotted. Basically, there are 2 forms that, again, you can download it on the left side upper corner of your screen, and they're from the Healthcare Authority 13-835 and 13-756. And again, you can access them on the links that are out there. So currently, what are the barriers that we see? Well, although awareness of the value of education has improved, similar barriers to access to diabetes self-management education exist in both developed and developing countries. The primary barriers to access to education is shortage of accessible workshops or classes, and additional barriers being the financial reimbursement or support for education. Some organizations may be taking it all on their own and not necessarily getting any reimbursement for the work that they're doing. Some organizations may have grants that they're utilizing in order to support these programs, but again, grants may last for so long. So we're looking for something that is actually sustainable. But again, other barriers that we see now, it could be due to transportation. Our patients may not have access to be able to attend those classes. Language barriers, as well as time. People or our patients may not be able to get off of work in order to be able to attend these classes that are out there. What are future solutions? Well, better understanding of current needs of communities and the use of community health workers could decrease the gaps. Not necessarily just community health workers, but we have patient navigators that some of the organizations are utilizing currently, as well as care coordinator, among other roles that may be helping currently to bridge these gaps. Another one that we are currently working on is having talks with managed care organizations to support preventive health education and finding out what are the current guidelines that they have in place in order to be able to support these particular programs. For more information in regards to programs that may be available around your community, you can go to the website Win211 and basically type your location, and it will populate the programs that are near you that offer either diabetes prevention programs or offer diabetes self-management programs. As well as you can go to the Stanford Patient Education Research Center, and it will give you more information about the Stanford evidence-based curriculums that are out there, as well as the organizations that are delivering them. And you can go to the Center for Disease Control and Preventions and find out more about diabetes prevention programs that are out there and are around your community. Here also at the end of the PowerPoint I have the list of resources, and again, that's downloadable on the upper left corner of your screen. You can access to all the links that I have there. And thank you so much for being part of this presentation today. And if you have any questions, I will open up for discussion right now.
Thank you, Alexandro. So if you have a question, you can use the hand raise man at the top of your screen, or you can type a question into the chat box. See, we're working on making you unmuted. Do you want to try talking and see if we can hear you? If you push the mute button on your telephone too, we'll still need to unpush it.
Oh, this is Sue Barwick from Mason General Hospital.
We can hear you. That's great.
Okay. It has long been a standard of Medicare to cover 10 hours of DSME, diabetes self-management education, with a newly diagnosed diabetic patient. And it is my belief as a certified diabetic educator that that is a minimum standard for a new diabetic. With the state Medicaid program providing only 6 hours, my question is there any discussion, is there any work in process to change that 6 hours to 10 hours for a newly diagnosed diabetic patient?
That's a great question. Yes, currently we are meeting with the healthcare authority, and those questions have been brought up. It's still under discussion, but one thing that I can say is that, again, those 6 hours are not limited to just 6 hours. One can actually apply for an extension, and you can get more hours throughout the year. And this is, again, something that is renewable every year. I don't know if that answers specifically the question, but
well, thank you.
This is Sarah Eve Styliker, and I just wanted to add that is an excellent question, and there are a couple of different avenues to raise that in. One would be the Washington Association of Diabetes Educators. Another would be the Washington State Diabetes Network Leadership Team, and there is representation from the Washington Association of Diabetes Educators on that leadership team. But if this is something that diabetes educators feel strongly about, that's really something that is important for us to know so that we can partner with Medicaid to address it. And with our state innovation model grant, that might give us some leeway to try out some different things. So please, thank you for raising that, and we know that there's a discrepancy, and all things pertaining to Medicaid have to be negotiated between the state and the federal government, but unless we know what it is that diabetes educators are recommending, we can't try to push on that. So thank you.
Did that answer your question, Sue?
Thank you.
So, and that kind of ties into one of the questions that I had. When you said 6 hours are available, I'm assuming that's 6 hours per patient, not 6 hours for the group.
Right, 6 hours per patient.
Okay, so it's 6 hours per patient. And then if they were to want to apply for additional hours for newly diagnosed patients with diabetes, could they apply for additional hours across the board for all patients who are newly diagnosed, or would they have to do it patient by patient by patient by patient?
They will have to do it patient by patient.
Okay.
Unfortunately, at the moment, that's kind of
In the current system.
That's what is stated in the current system.
Okay. Thank you. That's helpful. Are there other questions? While you're thinking, I have another question, and that is I've worked with clinics who did group visits, and I wondered if they could bill for the diabetes education portion of that group visit and still have the individual appointments where patients are seeing that provider billed separately in that setting. That's
actually a great question. So the medical portion of it will be different in comparison to the educational part of it. So definitely they can bill for the educational portion of it separately, I believe. Not necessarily it will be the same type of billing. As long as they're separating it within their system and submitting it that way.
Okay. Clinics I've worked with actually had the patients go into a room with the provider and have their individual appointment and then rejoin the group education.
Mm-hmm.
So I wasn't sure how that would work. Checking back with the audience again. Additional questions?
I would be interested in knowing if anyone in the audience has used that group visit model or if they've thought about it.
If you've used a group visit model, can you type your name over in the chat box? Looks like the people who are attending this morning haven't tried that one out. Oh, Pam's typing. So we'll wait for a minute. So it looks like Mason General is looking at testing a group for prediabetes. So they're looking at establishing a group of patients with prediabetes.
So also I wanted to ask, and thank you, sorry for that information. But yeah, are there currently barriers that organizations are having to go through in order to be able to get reimbursement either through Medicaid or any other type of funds that are trying to look for? What kind of barriers are you currently seeing in your organization, if you don't mind me asking that question?
So we have a comment from Mason General Olympic Physicians that rural health clinics can't bill for Medicare for group visits, can't bill Medicare for group visits. Pam, let me follow up with you outside of this webinar because we're coming kind of to the end of it here and see if we can find anything for that or get some more information. This is Kate Cross. And we're going to go ahead and go to the evaluation